Hi everyone, my name is Dr. Fiavi and welcome to my channel, Body and Mind Unplugged. In today's podcast, I want us to discuss therapeutic relationships and its impact on patient-provider communication. Have you ever been to the doctor and felt like your concerns are dismissed, you feel unheard or excluded? Well, research shows that right here in the United States, 22% of minorities are less likely to receive pain management as compared to their white counterparts. In Ghana and most part of Africa, 60 to 80% of patients fall to alternative medicine versus going to the doctor. Well, to help me discuss or dive into this gap in practice is three incredible healthcare experts. Dr. Onyalo. Dr. Onyalo is a very good friend of mine and a colleague as well. She is a 2 times board certified nurse practitioner specialized in family medicine as well as psychiatry and mental health. Also joining us all the way from Ghana is Mr. Jude Sindana. He is a board certified pharmacist. The last but not the least is Mr. Moses Njogu, also all the way from Kenya. He's a nurse intern. All these three healthcare experts are very passionate about healthcare delivery, patient advocacy, and policy change. So, ladies and gentlemen, welcome. So, Dr. Onyalo, can you open the floor for us? Many minority patients in the US feel that they are dismissed or labeled or unheard when it comes to advocating for their health. How does bias, whether consciously or unconsciously, affect patients and provider trust?
So thank you for the opportunity to be here today and discuss this much needed talk. So the research, there's several research studies and there's ongoing research studies about the biasness when it comes to race per se. So like we said, it could be consciously or unconsciously, which we usually call, this, they call it implicit bias. So in the long term, or even in the short term, implicit bias has a negative impact on health outcome, especially amongst the minority communities. So when a couple of years ago, there's research studies that they will look at what is the physician or the provider attitude during the appointment time or during discussing treatment options for the patient. So implicit bias will result in less trust between the physician or the provider, healthcare provider, in any cadre. It could be the nurse, it could be the pharmacist, it could be the social worker or the psychologist across the board. So when there's that low trust between their provider and the patient, we are likely to see a negative outcome or poor outcome of the patient treatment course the whole time. So then we are called upon, how then do we educate our people to advocate for themselves when they seek treatment in any healthcare facility across the globe? Because we had our own, you have to advocate for yourself because nobody will. So, but what's happening with a lot of us or a lot of our people is there's that gap of knowledge, or there's that respect that they give the healthcare providers, that I trust what you tell me, even if I don't know what it is. So sometimes we say yes, and then we don't do what the person was saying. So, how do we come in and create this atmosphere that enables the patients to express themselves, and also to get the best quality of care that they're able to get at that particular time? So as healthcare providers, we have a bigger responsibility because these people trust us. So how do we then treat them better? How do we listen to them?
So you did say that we have to advocate for ourselves. How do I advocate for myself when I already feel that I've already been judged? I'm not going to be listened to. I'm going to be considered a frequent flyer when I keep going back to my provider for the same thing. How do I advocate for myself when I feel like my provider thinks I'm difficult? I'm a difficult patient. I'm always demanding. How do I advocate for myself when my provider always have um, their own misconception about me as an individual just because um, I belong to a certain group of people? So would you say that the trust needs to be established even before the patient walk into the hospital? And how do we establish that trust? Does the burden of proof only lies on us as providers, or both ways? Both ways, because obviously as a provider, I want my patient to trust me, and I also want to trust them that they are going to be involved in the plan of care, or whatever treatment plan I'm giving them, they are going to follow suit. So the trust goes both ways. However, how do we get our patient to trust us as well as we trust in them? How do we work together?
So I guess this is where the part of active listening comes in. Are we able to listen to each other? Like, are they able to listen to me? Am I able to listen to them? Do I give them that space of to allow them to express themselves? So it's both ways, like you said, but it entails the whole healthcare team. It's not only the provider. So how we treat them from the get-go, as soon as they walk into any health facility, it could be that person at the gate, you know, the person's, like letting them into the facility. It could just start from there, like the reception they get from the gate can
Mm-hmm.
say a lot on how they're gonna perceive everything that is gonna come afterwards. So those little things matters at the end of the day. We may say, oh, the person at the gate greeted me, they were nice and stuff like that. So
Mm-hmm.
that welcoming atmosphere matters to somebody who's already in a lot of distress.
Thank you. Thank you for that insight. Now let me go to you, Mr. Jude. In Ghana, most patients are usually afraid to ask questions when they go to see their pharmacists or their doctors or generally their healthcare providers. Um, why do you think we have that culture? What do you think is the problem, and how do we break that or make it better?
Okay, so once again, thank you very much for the opportunity to be part of this.
Oh, I don't
Can you
think
hear
I
me?
can hear you. You're muted.
Can you hear me?
Check your microphone if you can hear me.
Can you hear me?
Dr. Onyalo, can you hear him?
No, I think he's on mute.
Yeah.
Hmm. I can hear you
Maybe
clearly. I
Moses
don't know
can
if
come in while he's still figuring it out.
Yeah.
I also can't hear him.
Okay. All right.
We can
Well,
hear
what
you now. Maybe you can
Moses,
talk.
Jude, Jude, if you can hear us, try and check your microphone. And Moses,
Yes.
can you give us an insight from Kenyans' perspective? Do you think this is a problem in Kenya? Do Kenyans find it difficult communicating with their providers and asking questions? Is the environment conducive for patients to be able to be open, to have communication with their providers? Is that
Yeah,
allowed?
sure.
Do they have that safe space?
Yeah, sure. It's a major problem, by the way, that we face in Kenya. The communication between the nurses, the doctors, or basically, let's say, the healthcare workers, when they are passing communication to the patients, it's more of a downward communication. It's an authoritative type of a communication where it's the patient on the receiving end, where the doctor or the healthcare worker gives now the instructions that he or she expects to be met by the other party. And now you see, due to high levels and the widespread illiteracy in Kenya, where that you do not you get that most of the patients do not understand even the basic knowledge about some diseases. So if this patient, whether he is rightfully guided or wrongly guided, you will just find them that either they follow and they limit to ask questions so that maybe they cannot create an impression where they seem like they are not well conversant with matters. So what happens is that whether you want to give information or you don't want, you get to find that it becomes somehow hard for the patient to accept one, because the main thing is that the patient should first accept that he is not in a position or in your position to understand the conditions and the treatment process as you can. But now due to the differences that now doctors and healthcare workers are viewed as somehow superior to almost all the other cadres, now it creates a very big gap between now the patient and the healthcare providers. So it becomes very, very hard for even the communication to take place. For example, you will find that the doctors prescribe medication, but due to now the widespread gap, the patient opts, instead of using this medication, maybe I should alter this prescription to meet, for example, to meet my own maybe to be economic somehow, or maybe is guided by some other people to try and be somehow friendly, maybe. You see, but now will we really meet the main goal or the set goals? So that remains to be a very big issue. Yeah, the gap in the communication, that remains to be a very, very big issue in Kenya. Yeah, sure.
Wow.
Yeah, that is so true.
Go ahead.
I can attest to that. I think several years ago, one of my relatives back in Kenya had a severe, almost like third-degree burn, and she was hospitalized for like I think several months. And the kind of treatment, I don't know how she was treated when she was in the hospital for all that time frame, but this is she got discharged with a couple of medication with no clear instructions at all. So she's there recovering from burns, and you discharge her with antibiotics and pain medication. Zero explanation. She has the medication, but she doesn't know what the medications are for. So she chose not to take the medication because she don't know what they are. So, and then you come from a background where nobody's gonna explain this is for this, and this is how you need to use it. So we have a person who is suffering in pain, but they have pain medication, but they are scared to use it because nobody explained, and they have in antibiotic. This is supposed to help them reduce any risk of infection. They are not taking it because they don't know what it is for. So this is basically what the physician, whoever is treating this person, what they are trying to achieve. They are not going to achieve it because the person is not aware of what you are trying to achieve to begin with.
Yeah.
They are not aware of what you are trying to achieve. So this is a case where they either ration the medication or they don't take it at all because they don't know what it is for. And then we have this notion that you should be taking medication for a long time. You should just take it for a little bit. So even if I give you diabetes medication, you think, oh, I'll take it for 1 week. When I finish, then the diabetes is gone. So then you end up people getting worse and complications, not because they want to get the complication, but because somebody failed them. And sometimes we have the language gap. You go and then the person is talking in Swahili and you don't understand Swahili. They're like, they told me I have, they have this crazy thing. They always say, I have bacteria. I'm like, what kind of bacteria do you have? Or they told me I have bacteria. I'm like, oh my goodness. So if you are the physician and you are telling your patient that they have a bacteria, you have the knowledge that the bacteria are very specific. Like you have this kind of bacteria, this is how we are treating it, this is your course of treatment. If it doesn't get better, come back. There's no such a thing as bacteria. There's no diagnosis of bacteria. We have to, but it is, we have this big responsibility as, people who know something too. But a lot of these people that we are trying to talk about, they come from backgrounds where majority of the people they interact with doesn't know either. So then nobody is helping the other person. So I think the other thing we can tell our people is that when you go to see a physician or you go to the health clinic, go with somebody who knows something. Somebody who can read what is, they have this, they used to write this prescription that the only person who can read is the doctor and the pharmacist. Nobody else can. So then they ask you, what's the medication? I don't know. They just scribble something and write 2 times 2, whatever, 5 days, and be like, what is 2 times 2 to 5 days? So it's sad. And a lot of people die not because they are supposed to die. That's the sad part. Not that they are supposed to die, but they are dying because somebody failed them with a very tiny thing, and then they die. And then we say, oh, they were just fine, and then they had a headache, and then they died. And nobody dies from a headache,
Yeah.
So it's sad. Let me just put it that
What,
way.
what on what
So,
Dr. Anyalo is saying, what on what Dr. Anyalo is saying, for example, you see in African countries, we have a big burden when it comes to this chronic illness because of the lifestyle and genetics, basically, and mainly when it comes to hypertension and diabetes. Now, you will get a patient who maybe has been diagnosed with both because they run somehow concurrently. It's hard to see a patient who is diabetic and exclude hypertension. So you will get this patient, he or she is diabetic, he or she is on medication, but basically he continues eating the same size of meal that he was eating, and then he tells you, no, the doctor just said I should decrease sugar intake, but the same patient is eating 3 plates of rice. Then what happens? The patient comes to you with complications of diabetes. Yeah, you just wonder who told you that you should not take sugar. You just take sugarless tea, but all the other things he continues doing them. One like nothing is happening. And so basically, you come to learn that this patient doesn't understand why are we saying that in diabetes you should decrease this and increase this. The patient just understands, diabetes. So it is an issue with sugars. I know how I'll do this. I'll not take sugar. I'll take sugar as tea. But basically, the patient is eating a lot of wheat, a lot of rice, and basically the patient worsens. Yeah. So it's our role as healthcare workers to play this important role of educating the patient. And also, even if we are talking about education to the patient also should try and understand that we also have guidelines that we work through,
Yeah.
and guidelines that we, for example, there is a hospital that is known as Kiambu. It's located somewhere here in Kenya, and in this hospital, we had the hospital taken to court like a year ago. And why was the hospital taken to court? Because a mother came in labor. She had what we call intrauterine fetal death. Then the doctors say, no, let us try and see whether labor will proceed normally. And so the relatives insist, no, this patient of ours or this mother of ours is going through a lot. Already she lost the kid. And now already you are telling us, no, let the mother try labor. So they went to court, and the hospital was held somehow liable because why don't you take this mother to a cesarean section? And you see now trying to convince now the relatives that we should not give this mother a CS scar with a dead fetus. Trying to
Oh.
convince the mother this and the relatives this, it became a nightmare to the doctors and to the consultants in the facility. Now you say even if we want to educate them, it is good also for the relatives to learn that we do some things for the betterment, yeah, of themselves and for the betterment and for a better tomorrow. You see,
But I
yeah,
think
I
it's
think I'm done.
how it is explained to the patient. Sometimes we have the doctors or whatever have this power dominance. This is what
Yeah.
we're gonna do.
Mm-hmm.
Maybe how it is
Mm-hmm.
explained can make if you come to me gently and sit me down and explain to me as a family, and then this is what is going on in simple grade 5
Mm-hmm. Mm-hmm.
terminology. This is what is going on with this particular patient. And for us to help this patient, we plan to do A, B, C, D, and this is what's gonna happen with A, B, C, D. If we do this other one, this is what's gonna happen. I think sometimes people pull out of the treatment plan because on how that information is relayed to them. When you come with a lot of power, and in our African setting, people come to the hospital, they have this crisis, and when you tell them, oh, if we do a C-section, we're gonna charge you 200,000. And this is somebody who doesn't even have 2,000. When you talk about 200,000, they're like, no, we ain't doing that, because there's that money thing, power thing, and limited resources and limited knowledge on how these things work. So if we just spend a little bit extra time
Mm-hmm.
to explain, I think they will always buy in because they want this person alive at the end of the day. So the
Yeah.
way you explain to them will make them make better judgment. But because we have the power dominance, the social dominance, our explanations are always like it's the verdict is already been declared. So
Mm-hmm.
either you
Mm-hmm.
take
Mm-hmm.
the verdict or you leave. So I'm left with a lot of limited limited
Option.
space to respond, and then factoring that I have limited resources. So I'm looking at the money thing, I'm looking at the life thing, and I'm looking at this doctor. You already said we're gonna do this, and then they walk out and leave you there to figure it out. So I think the way we come through with that information,
So
it's
we do have a lot to deal with. I mean,
the attitude.
what you guys just discussed or explained is no different from what is happening in Ghana. So I'm assuming this cut across board, the whole of Africa, pretty much. We have this authoritative lead way of practicing that our patients are even afraid to ask questions about their own health. Whatever the doctor says is final. I can't ask questions without agitating him or her. So
Yes.
let me not ask questions. Let me just keep quiet. I mean, I've had people back home in Ghana where I've talked to, they are sick, they go to the hospital. You ask them, what happened? What did the doctor say? Well, they gave me some prescription for medication. What did the doctor say is wrong with you? They didn't tell me. How did they not tell you? Or they just say, I have infection. What kind of infection? They
I
don't
think
know. What kind of medication? They don't know. You see? So the problem already started from the doctor's office, and then they go to the pharmacies, and then they get the prescription. They don't know the side effects of this medication. They don't know much about the medication. They don't know how it works. They just know that they have to take this medication. And then they also don't know that, some of them don't know that they have to take the full course, especially when it comes to antibiotics. They take it 1 time, 2 times, they feel better, they stop taking it. You have people taking antihypertensive medications and diabetes medications, PRN, as needed. They take it, yeah, they only take their high blood pressure medication only when their blood pressure is high. And as soon as it's low, they stop taking it. So that is where education comes to play. Like, we cannot stop educating our patients enough, because if they don't know the mechanism of action of this medication and how they're supposed to work in relation to their disease process, it's going to be difficult for them to be compliant. And
yeah,
then,
we can hear you
yes,
now.
Jude, welcome. We can hear you now. I was asking you about your insight from Ghana's perspective, and our colleagues here talk about how difficult it is for patients to ask questions because of this authoritative mode of practice back home. But I want to ask you again this question. Do you think that provider burnout and lack of resources play a big role in how providers or healthcare workers communicate with people? And also, do you also feel that patient non-compliance or excuses makes it difficult for providers to work with them sometimes? For example, let's say a patient comes to me in the hospital, right? I have my differential diagnosis, but I need them to go do these labs or go do these imaging studies. And then they are telling me they don't have money. Oh, doctor, please, I don't have money. I can't do this. I can't do this lab. I can't do this MRI or X-ray. That leaves me hanging. It puts me in a difficult place because now I can't give you a definite diagnosis. So you can't really blame me. And then they come back when the situation is worse. Do you think this also has a big impact on the provider patient therapeutic relationship?
Okay, so first of all, I think that you guessed right. The main issue is burnout. First of all, if you look at the patient doctor ratio, patient nurse ratio, patient
Mm-hmm.
quick ratio, usually is 1 to over 30,000, 40,000 in certain places. So imagine one doctor attending to 40,000 people. Definitely not all are coming the same day, but if we do the math, you can see that there's going to be severe burnout. And looking at patients' load, the usually it's not an excuse, but most people will say you don't have the luxury of time to take one patient through systematic explanation of everything they need to know. I think that's basically one of the reasons. But then again, I think that is because it's not necessarily um, the issue of power play where the prescribers or whoever it is who's attending to the patient has some level of superiority complex, but it's also because usually the patient doesn't know what they don't know the kind of power they have to be able to interact with whoever is taking care of them. So the WHO has a patient charter, which is the patient's rights and responsibility. It's a lot. Maybe I should mention just a few of them, just to help us and give us an idea.
Mm-hmm.
So one of them, so the Ghana Health Service has broken it down to make it simpler to understand for everybody. So one of it says that um, okay, so there's another issue. The issue is that for some of them, the whoever is in the hospital is not at fault. Let's take for instance, one of the patient's rights is the right to quality basic health care, irrespective of his or her geographical location. If we take that one, if there's no hospital in a city or a town, I don't think um, the person who is taking care of people there is to blame for that. So then when we take that one, then we are looking more of the issue of resources and how the setup is in our various places. One which I think patients need to know is that the patient is entitled to full information on his or her condition and management and the possible risks involved, except in emergency situations where the patient is unable to make a decision and the need for treatment is urgent. So for when you take this one, if every patient knows this, there's no way a doctor or whoever is attending to them can just brush them off or say I'm in a hurry, so please leave and let another person come or any of those things. Because he's supposed to once there's something you need to know, they are supposed to let you know. Sometimes it's it can be, let me use the word, irritating when as a pharmacist the patient has come to you, has gone to see the doctor, has gone to do labs, has done everything, and sometimes a drug has been prescribed for the person. The person comes to me to ask me that what did the doctor say is wrong with me, or what is this medicine for?
What did the
Sometimes,
doctor say is wrong with me?
so sometimes you wonder, but you were sitting in front of the doctor the whole time. You told the doctor what exactly is wrong with you, and drugs have been prescribed for you. I kind of um, learned it. I don't want to say the hard way. It didn't happen me serious effect. But then what happened was a patient had asked, "What is this medicine for?" And you know, there are a couple of drugs that don't treat just one condition. So if you should go and without knowing why the person came, you should go and give an explanation. You say this is not what is wrong with me, and he won't take the medicine.
They won't take it.
Meanwhile, meanwhile, the medicine can handle a plethora of like conditions. So I think patients just need to know um, how or the kind of power they have. Quite recently, I don't know of other African countries, but then in Ghana and I know in the US, there are many lawyers who are just going around looking for patients who have been victims of medical negligence just to take the case up for them to make money. And a lot of people are just going around to like various hospitals just to, of the hope that something would go wrong so that they can make money out of it. So I think that as health practitioners, we should take our time, we should be patient. Another issue, sorry, the issue just keep coming to mind. That's why I keep
That's
saying
all fine. That's why we're having this discussion.
another issue is it looks like nowadays in a part of the world, a lot of people don't have jobs. So they look at what is easier to get, like the kind of job that is easier to get, then maybe they pursue it. So you see, let me use usually we use nurses. You see a lot of nurses in the system. Most of them don't even have jobs. The ones who have jobs too, most of them it's not like it's their passion or it's something they love to do. They are there because of condition, because man must survive.
Actually, we have that here too. I'm seeing a lot of that in recent years. Dr. Nyalo, you can attest to that. We were just talking about some of these young nurses these days. Gone are the days where people get into the profession because they have the passion for it. Now people get into the profession because of job security or what have you.
That
So they get in and then every little thing is irritating them. They are easily frustrated and burn out and taking it on their patients. So it's a problem. I think it's a worldwide problem.
that's very
Yeah,
true.
it
But
is
But
how
a
then
in
again,
worldwide.
in Africa, how do we encourage patients to advocate for themselves? Not just in Africa, even in the US, where minorities, the research has shown that minority patients have always complained that they feel unheard, they feel excluded, they feel discriminated against. How do we encourage patients to effectively advocate for their own health? Because I believe that when it comes to treatment plan, the patient should be the architect of that design. They should be the architect of that treatment plan. There's no way I'm just going to draw a treatment plan if my patient is not involved. As providers, we need to discuss options with our patient. We need to let them know why we are giving them these options. What are the pros and cons? Let them be involved so they know exactly what to expect.
I think
Moses says something about an incident that happened in a hospital in Kenya. As a pregnant woman coming to the hospital, they shouldn't just be hearing about a cesarean operation as an option when they are already at the finish line. The treatment plan should start before you get to that stage.
Yeah, sure. Now, the issue is, let me echo something that Nawunde had just said. Um, you see, the main issue, for example, in Kenya, let me talk specifically about Kenya because it's things that we encounter day in, day out. We have the WHO recommended ratios for nurses and all the healthcare workers and the patients. For example, they say in a critical care unit, we should have one nurse or one doctor per patient, specifically for the nurses, one nurse per patient. In a surgical ward, if you do one nurse for patients, it's somehow rational. But now in Kenya, you will find a ward having 60 patients, having two nurses.
Wow.
Now, here we are not interested in we are not interested in the quality of care. We are interested in the quantity. Did you issue all the patients their new medications? Yes. Not about. Did you do bed baths? Yes. How effective was the bed bath? How effective was the
Effective is bed bath for 60 patients via
yes.
there's two nurses, yeah.
You just do for quantity purposes, not quality. So the burnouts and the unemployment issue raises another concern. Let me comment on what you were saying or what you were asking. How now would we improve? How do we improve so that we can ensure that patients participate in their own care? One, I would like to talk about education and creating awareness. I don't maybe because I believe that we are all medical workers. I hope you have encountered a patient, for example, a patient who is for dialysis, whether it's hemo or peritoneal dialysis. Sometimes you get to see that this patient is much conversant with this procedure and the condition to an extent that he or she even gives you information that finds you off guard, that you even say, hey, that information, to be honest, I didn't know that there was such guidelines because this patient has had this condition for the last 5-10 years ago. You see, so this patient has been educated, has tried to research, and due to their personal interest, they have come to learn about these things. But so when we create awareness and when we create education, this patient will come to learn about their rights. For example, in Kenya, we say that this patient, the patient has a right, one, for refusal of treatment, and these you will get these in private healthcare sectors, where you go into a hospital, take your patient there, or the patient comes, and if you don't give adequate information, the patient will say, no, I don't intend to receive that kind of care that I don't even understand. So when we create awareness and we create education based type of these patients will receive information. For example, Kenya, we have non-compliance to TB medication, but currently it's decreasing somehow. What do we do now to this TB patient? This patient contracted TB, takes medication, and you know the side effects that are the side effects that come with the TB medication. There is diarrhea. It causes a lot of discomfort to an extent that you even feel they are not even palatable. So what happens? This patient takes the medication for 2 weeks, 1 month, and then the drenching night sweat, they subside, the cough subsides, and the patient says, I'm healed, wonderful, and leaves the medication. So what happens? Then after a few months, a few years, the patient comes back with the same condition. But now with education, this patient has to understand whether you are coughing or not, you still have the condition. But when you do this and do this, these are the do's and these are the don'ts. The way now we come to a point of eliminating this disease. And two, it's about the hospital policies. If we create a policy, for example, that is more of hospital-based policies, that gives guidelines on how patient-centered care should be, how patients should be educated about their illnesses and ailments. It provides a plateau for the patient to learn about their conditions. For example, for a patient to be taken in theater in Kenya, they really undergo education. You explain to this patient that apart from even you're going for an IM nailing, you're going for a PFNA. Okay, leave that alone. Apart from that, you will be under anesthesia. It will be a general anesthesia, it will be a spinal, it will be a regional, it will be a local, whatever. You explain to the patient to an extent that the patient sees and even the patient is part of the surgery that is going to occur. But why do this happen? Because this happens because so many doctors have been taken to court over the same. You take a patient to theater, and then later you come to notice the patient had not signed the consent. The patient now, due to these issues, the hospital policies say this patient must be educated conversantly. The patient must be well aware of what is going to happen and what will be what's this procedure we are talking about. So when we improvise or when we bring about matters about policies, policies can also help us attain patients' education and also patient contribution towards their care. Thank you.
I couldn't agree with you more. Education, 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 public health advocacy, policy change, something must be done. Because, I mean, right now we have a lot of kidney disease and kidney failures on the rise. But in Africa especially, we have a lot of people with high blood pressure, untreated, diabetes, unmanaged. Meanwhile, research shows that the number one cause of kidney failure is high blood pressure and diabetes untreated. It is very rare to have a patient who has diabetes and doesn't have high blood pressure, or have high blood pressure and doesn't have diabetes. They usually have both. Like Moses said earlier, you have somebody that thinks that because they have high blood diabetes, they just have to avoid taking sugar. Meanwhile, they're eating ugali in the morning, rice in the afternoon, jollof again in the evening. Who is educating these patients? Even at all, if they are educated, can they afford their lifestyle of eating healthy? That's another thing we have to talk about. So it's a long list. It's a long list. It's a long list, and it's a responsibility that lies on both patients and providers. I don't know where we're going to start from, but I guess we are starting from somewhere by talking about it. People need to be well informed. Medications, certain medications are not what some patients don't understand in Africa is that there are some medications, some high blood pressure medication that you cannot just stop abruptly. It will do more harm than good. So you don't get prescribed a medication that take it for 3 months, come back for a review, you take it for 1 month, and then you just decided that cold turkey you're going to stop. There are some medications that you need to be tapered off slowly. Are we explaining this to the patients? Or are they stubborn to listen? Are they just stubborn that they are not listening?
It's both.
Where do we take this public health advocacy to? Where do we start from? Where do we start from when we have a provider burnout? One provider with hundreds of patients line up. Do we take our time with one patient and make sure they are well informed and well educated before we move on to the next patient, or we just rush through them because the rest are also sick and they need help?
It's like a compounded. I would say it's a compounded thing that falls off, and because I can imagine myself having 60 patients. I will have a bad attitude. I'm not gonna lie. So so if you see the burnout and the patient, like if the provider is having a burnout, they are more likely to deliver a low quality care. So that's a given. And then we have an informed society that doesn't know what needs to be done. And like Jude said about we have this patient right. How many patients know their rights? Not a whole lot of patients know their rights. And sometimes it's even encouraged that when you go to see your doctor or whatever, it's good to go with somebody else. So if you don't understand, then maybe the other person has a little more understanding, can ask, specific questions. I remember in Kenya, in Kenyatta National Hospital, they have this very nice program for diabetes education. So if you go there, you get diagnosed with diabetes. They have a whole couple of weeks education, and normally they recommend that if you are the man that is being diagnosed with diabetes, they recommend that in when attending the classes, you come with your wife, because she's the one who is cooking, she's the one who is buying the food, so you will come with half information. So if the wife is there who is doing the food prep and all that stuff, then they know what needs to be done to save this person from these other complications. So we have to look at it. Some of these chronic issues, it's a family affair. It's not just, when I'm sick, it as a it's gonna impact the whole family. So when we look at these things as a family affair, then we're gonna help as much as are the patients able to ask relevant questions. That's up for debate, because you can't ask a relevant question when you don't even know what your diagnosis is. So, after the time they'll say you have malaria, you have typhoid, you have bacteria, you have bacteria.
Yeah, bacteria, like you said, bacteria is not a diagnosis.
That's what they tell them though. And then now they have, we recently have realized in Kenya they have this influx of teenagers being diagnosed with ulcers. So they tell them, oh, you have ulcers. So I'm like, why there's a widespread of new diagnoses of ulcers among teenage going high schoolers? Nobody is explaining, but I haven't talked to a whole lot of them, but the trend is, I was in high school and I know I didn't have ulcers, but I'm like, why do these kids all of a sudden have these ulcers? Why would a 15-year-old have, ulcers, stomach ulcers? I don't know if the doctors are just saying or it's real, because there's no actual test that is done to these kids. They just tell them you have ulcers, you have malaria, you have typhoid, you have bacteria, and so education is the way to go, and it starts from. I think Kenya have this very nice program. They're just mismanaging it, but it's really nice. It can help a lot. They have community health workers. So these ones are their instrument to go into the locals, because they speak the same language, they eat the same food. So if these people are used well, there's gonna be a change in everything, the numbers. But it's just they play politics with people's life, and it's not pretty. It's not pretty at all. So education, we have to start from somewhere. Even if you just say you have malaria, and this is how we treat malaria, and this is how you prevent malaria. Because we don't just want to treat it, we want to prevent it. We just don't
Exactly.
want to treat diabetes, we want to prevent diabetes. We just don't want to treat high blood pressure, we want to prevent it. It's cheaper for the society, it's cheaper for the patient, it's cheaper for the healthcare system. So we want to prevent, we don't want to treat as much as we like to,
Exactly.
but we want to prevent.
Jude, do we still have community health nurses in Ghana?
We do. We do.
So they have community health nurses, and then they have community health promoters.
Yes.
So those ones
Yeah.
are two different cadres. You know, we have community health nurses and we have the health promoters, who their
Mm.
focus should be on prevention and
Mm-hmm.
prevention. It's just that they don't pay
Education and education.
they don't pay the bill, so they don't even care to do the job. Nobody wanna work for free.
The-
Don't blame them for free. But it's
sometime back they were remunerated by USAID. And
it,
yeah, USAID was remunerating them and used to buy them bicycles and maybe give them a small token. But these days, USAID is not there.
yeah.
Officials are using Google.
It's a very good thing. Those health promoters, because they are the backbone of community health workers, because they
Mm-hmm.
report to community health workers. So, because they can go to that little village, because the community health worker, they give them a very big uh, area to cover. So if you are given like a whole district, it's a lot for one person, because that's a lot of people. But if you have three or more community health workers per sub location or so, then it makes it easier, because they can report to you and say, oh, you know, in this community, this is what is trending. This disease is trending. There's this numbers, you know, there's this number of people with STIs. So you need to go there and figure out, where's this STI coming from,
Mm-hmm.
you
Mm-hmm.
know? Because we don't want to come and then now it's full blown that somebody has to be hospitalized for the STI to be treated. So that's where we are. It's those health promoters, they are not expensive. We just if they are managed well, they can save the healthcare system a whole lot. But people just want to play. So there's nobody for you but yourself. So our job is just to educate our people, and you know, after the time, tell them, if you go to the doctor, ask ABCD. At least tell them to tell you the diagnosis. Because if you go to the pharmacist and ask them what's wrong with me, I'm like, what's wrong with you? I don't know.
Jude, Jude had a duty of being the doctor and the pharmacist at the same time. So hey,
And
they're not just there to pick up their prescription. You have to tell them what the doctor said is wrong with them, educate them on it, and then educate them on the medication as well.
But June doesn't have the full information. They only have the
Exactly,
prescription.
exactly,
So what if
exactly.
the prescription is used adjunctly? So you may be saying, oh, you know, they gave you this for your migraines, but the person is probably treating seizure or something. So you know, Jude doesn't have the whole picture of what happened over there. And after time, our people are so impatient and with the listening. I don't know if they just don't have time. Like, you know, you say, wait a minute, I explain. They're like, I gotta go to the market. Please go.
You see,
Well, ladies
Mm.
and gentlemen, seems like our time is almost up. This conversation, we have to continue part two because, oh, it's getting interesting. Your last thoughts, Jude.
There's a lot I have to say, but still we have
What do you have
to,
to tell your patients?
they
And what do you
shouldn't
have
be,
to, how do you advocate for yourself as a healthcare provider? How do you advocate for yourself? You know, so that this burnout and lack of resources issue can be heard by the right authorities, and hopefully solution may come.
the issue of burnout generally is the issue of recruitment, and especially into government institutions. The last recruitment, if I remember correctly, was 2021. This 2021, the government has not recruited any pharmacists into the system. And even with that recruitment, the number was about 300, which brings the total number of pharmacists in the government sector, if I'm not mistaken, to about 900 or almost 1,000. The rest are
Wow.
private pharmacies. Generally, so it's more of a governmental issue. If the government is able
Mm-hmm. Because it
to,
doesn't make sense that we have this ridiculous patient provider ratio, burnouts, and then we have people out of school and they are not being employed. It doesn't make sense. We need people to be deployed into the workforce to help salvage.
oh yes, yes. For that one we do. We need a lot of people, a lot of people. But then again, the government will also um, be on the side of lack of revenue and all those things to pay so much workers. But basically, the issue of health is the patient's responsibility. I think that should be my last. It's the patient's responsibility. If the patient decides not to take good care of themselves, you would you may not even get good treatment. You would use money. You would spend a lot of money to treat. As Dr. Marion was saying, um, you just take care of yourself. It's your responsibility. Even as well, even though it's a family thing. And on the family issue, there are a lot of people who don't even want their family members to know exactly what is wrong with them. So if you say it's a family issue,
Mm-hmm. 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 Mm-hmm.
I may beg to
Mm-hmm.
differ a bit. There's a lot of people who don't want their family members to know what's wrong with them.
That they are
But
sick, yeah.
the whole town will know what is wrong with them. So that one is also another side. But then basically the patient's responsibility to make sure that you take good care of themselves to prevent whatever conditions may come. Rather than meeting and going to the hospital and expecting um, good treatment. I think prevention is the best. Thank you.
Well, viewers, all good things must come to an end. We definitely gonna have a part 2 of this discussion. But like my colleagues here said, take care of yourself. You only have one health and one life to live. When you go to the hospital, you advocate for yourself. Ask questions. When you prescribe medications, ask questions about it. Take it just as prescribed. Do not take your blood pressure medication only when your blood pressure is high, and stop taking it when it's low. Yes, your doctor may find it necessary to discontinue your medication, but it has to be a collaborative agreement after lifestyle changes and monitoring you and so many other things. You don't just stop abruptly. That blood pressure was low on that very day because you were taking the medication. So stopping it will not be helpful. Let's take care of ourselves. We have one life to live.